Welcome all. Today we will be discussing one of the very important topic, that is management of traumatic brain injury. So I'm not going to say in detail what is the management of each condition, but what I'm going to give you maybe in the next 15 minutes is going to be an overview of how you need to manage a traumatic brain injury that is coming into the emergency department, and what are the interventions that you need to do. There are a lot of queries in our mind whether all the patients with head injury need a seizure prophylaxis, when to give mannitol. So these are all confusion, when to call the neurosurgical team, what imaging need to be done. So there are a lot of confusions in this regard. So we will try to clarify that at the end of our presentation. So let's start. So, when you have a patient that is coming to the ED with a traumatic brain injury, we should have always a checklist bar priorities in our mind. So, whatever I am presenting is from the something called as ENLS guidelines. So, that is the European Neuro Life Support Guidelines. That's the first page you would have seen, the ENS logo. So, I am presenting from those guidelines as per the ENLS protocol. So, what are the checklist and priorities? So, the most important priority is securing the airway and maintaining a normal ventilation of a PaCO2 of 35 to 45 mmHg. Then the next priority is the hemodynamic stabilization. So maintaining a blood pressure of above 110 mmHg for patients between 15 to 49 years or above 70 years, and maintaining an SBP above 100 mmHg for patients between 50 to 69 years. So that is a target that we need to achieve. So whenever we discuss regarding head injury, very priority should be given to the hemodynamics, because cerebral perfusion should not be affected due to your decrease in the blood pressure. So hypotension is one of the major issue that you should not have in a patient with a traumatic brain injury. So these are the H's that you need to remember. There is most important one is hypotension, and maintain a saturation of above 90%, restrict motion of C-spine, and determine of post resuscitation GCS score, pupil size, symmetry, and light reactivity. Suppose you have done a resuscitation, this thing should be monitored very frequently. And if at all, if the patient develops a herniation, you need to know how to treat the brain herniation and management of raised ICP. Also, when to obtain a CT head and a CT C-spine, neurosurgical intervention when it is required, and a consult. Correction of coagulopathy is very, very important, because majority of these patients are now on antiplatelets, anticoagulants, newer oral anticoagulants. So these are all, many of our patients are on this. So you should know how to correct the coagulopathy, and who all need a seizure prophylaxis. Again, when to repeat the GCS and pupillary examination, that need to be done hourly. So that's the very important thing. Suppose in the initial phase, maybe 15 to 30 minutes you need to assess the pupils and the GCS, but later on hourly you need to do that. And mostly you need to have a very good coordination of a safe inter as well as intra hospital transfer. So during the transportation is the major time that the patient can deteriorate. So you should make sure that you are having a safe inter and intra hospital transfer. So these are the checklist bar priorities. So communication while you're transferring or you're giving a handover, this is the part that we haven't seen in many, but it's very important as an ED physician that you are transferring a patient or you are receiving the patient. The while transferring and handing over, you are giving one from one shift to another shift, or you are giving to and handing over to another specialist. You need to keep in your mind that these are the general things that you need to do while you're doing and handing over. Age, sex of the patient, what is the pre-injury health, including home medication, specifically on antiplatelets and anticoagulation, mechanism of time of injury, LOC if any, seizure, post-traumatic amnesia, whether it was a helmeted or non-helmeted, post-resuscitation GCS if you have done any resuscitation, pupil size, shape and reactivity, head CT if done, the findings of the same, state of C-spine, whether it is clear or not clear, and other injuries, any injuries that you have suspected which you need to evaluate further, or you have evaluated and you have found out something, and current vital signs, current ventilation therapy including ETCO2 and most recent blood gas, labs specifically to the coagulation parameter, CBC, sodium, blood urea, nitrogen, creatine, alcohol level, if you have done any urinary tox, treatment provided, reversal of anticoagulation if done any, blood transfusion and seizure prophylaxis, neurosurgical plan for surgery, ICP monitoring needed or not. So it's a general handing over that you need to do from one shift to other shift. Suppose you are going off your shift at 8 o'clock in the night and another person is coming. This will be an ideal thing that you are going to give for a head injury victim, so that you will have a structure handing over in your ED. But this is just specifically what I have said is for a head injury. Specifically, you are referring to another hospital. You have resuscitation, but you don't have a neurosurgical facility. You want to refer him to out to another hospital. So these are the general guidelines that you need to follow. And this is a sample sign of narrative. So, hello there, I am signing out a 42-year-old man who presented tonight after a high-speed motor vehicle accident that occurred at 11 p.m. The patient was driving and lost control and was found on the road about 20 feet from his motorcycle. So, it's a high-velocity injury. The accident was witnessed. There was positive loss of consciousness and he had one conclusive seizure lasting about 1 minute, which is witnessed by the EMS. He was wearing a helmet. Initial GCS on the scene was 4. Post-resuscitation GCS here in the ED is 7. He was withdrawing symmetrically and moaning before intubation. Pupils are about 3 mm and briskly reactive. Head CT shows a 4 mm acute left SDH and bifrontal contusions. CT C-spine was negative for fracture, but C-spine is not clear. No other injuries were identified on his primary or secondary survey. He is intubated and hemodynamically stable. SBP of 120, SATs of 96 on FiO2 of 60 and PEEP of 8 and NETCO2 of 35 mmHg. Labs coagulation were normal, sodium of 140, platelets of 240. He has received levetiracetam 1 gram IV and 1 liter normal saline and no blood products. Neurosurgery has been consulted and plans to place an AEV drain as soon as he gets to the ICU. He will be transferred to the neuro ICU bed number 4. So it's a sample narrative. So just in case you wanted to do this, this will be an ideal way by which you are giving a sample sign of narrative. So that is for your reference. Coming to the next, classification of traumatic brain injury, diagnosis and classification. Traumatic brain injury is defined as an alteration in brain function or other evidence of brain pathology caused by an external force. It's that simple. And mild traumatic brain injury, you have a GCS between 13 to 15. You have moderate traumatic brain injury where your GCS is between 9 to 12. And you have a severe traumatic brain injury where GCS is between 3 and 8. The GCS score will be affected by hypotension, hypoxemia, sedation and paralysis. So when you are assessing this, you should be knowing whether the patient is having on any medication, whether any sedatives has been given, whether he's been paralyzed. All those things you need to consider. Ideally, it should be recorded in the ED following resuscitation and prior to administration of sedation of pharmacological agent, which all we do. So that's for your clarity. And coming to the next thing, this is how you need to look into the GCS. Everyone knows there's a simple, you have 3 parameters, eye response, motor response and the verbal response. You have maximum score of 50, minimum of 3. In the eye response, you can have maximum of 4. In motor response, you can have maximum of 6. And in verbal response, you can have maximum of 5. So you should know how to calculate a GCS. So I'm not going to take much here. So most important thing, this is what as an ED physician or any of the paramedic or whoever is dealing with head injury patient need to keep this in mind. Already an injury has happened, so we need to prevent secondary brain damage. So secondary brain injury, it should be applied throughout the continuation of the care of traumatic brain injury, not just in the ED, in the ICU, in the ward, wherever the patient is. This needed to be done. So that's a priority number 1. And high risk for secondary brain injury from hypoxia, ischemia, hypotension, hematoma expansion, cellular edema, brain compression, intracranial hypertension, seizure and fever. So you need to keep them that these are the problems that whenever you have a secondary brain injury, already the existing brain injury can worsen. So you need to avoid hypoxia, you need to avoid hypotension, you need to avoid hypoglycemia as well as hyperglycemia, hyperpyrexia again needed to be avoided. And these are the key things that you need to prevent the secondary brain damage, and you need to identify them and you need to treat them very, very quickly also. So coming to the pre-hospital care, what are the pre-hospital things that you need? 50% of all deaths from traumatic brain injury occur within the first few hours of injury. So that's the sad part about it. And priority in the pre-hospital setting again includes spinal motion restriction, ABC maintenance, saturation to keep above 90s, SBP of above 100 to 110. I said the age range in the initial slide. obtain a relevant history, mechanism of injury, medication, LOC, post-traumatic amnesia, post-traumatic seizure, determine the GCS, pupillary examination, avoid prophylactic hyperventilation, maintain an ETC of 35 to 40. There is no role for prophylactic hyperventilation in a pre-hospital or even in the ED setting, and treat brain herniation if you find any. So we'll see how will you treat brain herniation. Coming to the ED, the trauma victim should be assessed, resuscitation and stabilized as per the ACLS protocol and the ATLS protocol that we all need, and if required for the pediatrics and the maternal cardiac arrest or the traumatic cardiac arrest algorithms. And the priorities of resuscitation should include hemorrhage control, assessment and stabilization of circulation, ABC, obtaining IV or IO. Because here I have just hemorrhage control, I have just a little bit put up because circulation is very key, because further deterioration in blood pressure can lead on to further decrease in the cerebral perfusion pressure, as the cerebral perfusion pressure is equal to MAP minus intracranial pressure. Obtain IV or IVO access, fast assessment for internal bleeding, maintain a stats of around above 90, SBP of 100 to 110 and PSUT of 35 to 45 or 35 to 40. Avoid hypotensive resuscitation in the terminology of a traumatic brain injury. So balanced resuscitation, hypotensive resuscitation or permissive hypotension should not be done in case of a traumatic brain injury. If post-resuscitation score is less than 8, rapid sequence intubation and activation of institutional severe traumatic brain injury protocol should be done. So you will have your own protocol. And imaging, the most important one will be head CT. If needed, other imaging as per the patient's stability. Associated spinal injury to be considered. C-spine injury may not be ideal. C-spine X-ray may not be an ideal, but maybe you need a CT C-spine. So C-spine, if you are not able to get a proper X-ray, there is no point in getting a C-spine X-ray. So if you have suspicion in mind, go ahead with the CT. So that's what the present recommendations are all about. And avoid hypoxemia and hypotension, that's already have told you. Post-injury hypoxia and hypotension result in secondary brain injury and must therefore prevented. Hypoxia defined as saturation of less than 90 or a PO2 of less than 60. Hypotension result in brain hypoperfusion. I have told you how it does happen. And the most key thing, you need to maintain an SBP of 100 to 110 mmHg for adult, and this is the age group that I have said. And for children, SBP should be maintained for at least above the 5th percentile, that is 70 mmHg plus age into 2. So the systolic blood pressure should be for like a 3-year-old child, 3 into 2, 6, should be above 76 mmHg. So that is the minimum recommendation for a patient, for a child with a head injury. Coming to treatment of brain herniation and raised ICP, signs of intracranial hypertension or brain herniation you should be aware of: dilated or non-reactive pupil, asymmetrical pupils, motor examination that responds, that demonstrate an extensor posturing, progressive declining in GCS, decrease in GCS of more than 2 points that are not associated with non-traumatic brain injury causes, like it is not due to a hypoxia, not due to a hypotension. And you will be seeing something called as Cockroach-Cushing reflex, that is hypertension, bradycardia with irregular respiration. So these things you need to keep in your mind. And management of raised ICP of more than 22 mmHg as in the ED. How all you need to do this? You need to elevate the head end of the bed 30 degree, drain CSF if available by an external ventricular drain, hyperosmolar therapy, so that you can use either mannitol, bolus 200 to 300 ml of 20 ml mannitol, IV bolus of hypertonic saline with a target sodium of 145. Optimize the cerebral perfusion pressure by making SBP above 100 to 110 and cerebral perfusion pressure around 60 to 70 mmHg in adult. Mild hyperventilation might help, that is you need to maintain a normal PCO2 of around 35 to 40. Optimize analgesia and sedation, maintain normothermia, again very very important, and start continuous EEG monitoring and treat the seizure if any. So the next algorithm what I have shown here, you have patient with an intracranial hypertension or herniation. Tier 1, this is the tier system. So tier 0, you have standard measures like assessing ABC, minimizing the noxious stimuli, analgesia by sedation, targeting normothermia, head and elevation, no compressions over the neck midline, iso or hyperosmotic fluids, avoiding or correcting hypothermia, obtain a non-contrast CD. So that is the tier 0. When coming to the tier 1 measures, you have again hyperosmolar therapy, you have temporary hyperventilation to a PaCO2 of 30 to 35, very rarely. CSF drainage, consider surgical decompression, and tier 2 measures are hyperosmolar therapy for higher sodium goals, optimize sedation and analgesia, rescue decompressive surgery should be considered as a life-saving intervention, and tier 3 you have sedation titrated to ICP goal or a burst suppression on EEG, then you have hyperventilation to achieve mild to moderate hyperventilation of PSU of 25 to 34. These are all very rarely you need to do. Moderate hypothermia targeting a cold temperature between 32 to 34. So you have got a tier based system. So tier 0, tier 1, tier 2, tier 3. Depending upon each system fails, you can go on to further down. So that is when you can have a question on it and you can manage the same way in your ED also. Coming to the hypertonic saline and mannitol, the dosing you should be very clear. It is 0.5 to 1 gram over 5 to 15 minutes, can be redosed every 4 to 6 hours. Rebound ICP elevation with abrupt discontinuation can happen, and also it can lead on to acute kidney injury, dehydration, hypotension and electrolyte imbalances, and may require warming to dissolve the crystalloids. If before, sometimes it can become crystalloid, so may require warming. May be given via peripheral access, and duration of effect is 90 minutes to 6 hours. And hypertonic saline, monitor, you need to monitor your sodium 4th hourly to 6th hourly, and target sodium is 145 milliequivalents per liter. So for that you need to give your hypertonic saline. Coming to the next one, optimizing the sedation and analgesia, aid in the ICP management. Propofol has been shown to reduce the cerebral metabolic demand and cerebral blood flow, but the problem with propofol, it can sometimes cause hypotension, so you should be very careful. So if you are using 1 to 2 milligram per kg is the dose, maybe continue as an infusion in ventilated patient at 200 microgram per kilogram per minute. And propofol, especially when given as a bolus, is associated with circulatory depression. That's what I told you. A small subset of patients receiving propofol may develop something called as propofol infusion syndrome, where you are having metabolic acidosis with dysfunction, cardiac dysfunction, rhabdomyolysis and hypertriglyceridemia, which can be fatal. So you need to be careful. And propofol infusion syndrome is most likely to occur when you are giving it more than 70 microgram per kilogram per minute for more than 48 hours. That's a usual we don't give. If propofol is infused at extreme doses, it should be done only temporary, while other corrective measures have to be done. So you need to look for other corrective measures. And one more drug, pentobarbital, not very commonly used in our ED. So it's a tier 3 mechanism. So pentobarbital 5 to 15 milligram over 30 minutes, that's the dosing. Some patient may not tolerate boluses, so you need to be careful. And it has got arterial vasopressor as a necessary. If needed, you need to start on arterial vasopressors as necessary for hemodynamic support, and EG should be continuously monitored, and phenobarbital infusion is continue for 24 to 96 hours, but routinely we are not doing. But high dose pentobarbital can mimic signs of brain death, so that you should be very careful. So it's only done in tier 3. So if at all you want to use 5 to 50 milligram per minute is per kilogram is the dosage, and you can start as an infusion also. Very rarely we recommend that. Coagulopathy correction, very important. Early recognition and treatment is the key. Incidence is very high. Coagulopathy associated with trauma has several possible mechanisms, but in TBI the principal process involves tissue factor releases. So study of tranexamic acid in traumatic brain injury for hemostasis is ongoing, and it can be given. So you can given for other hemorrhagic shock. Yes, it's proven. Now the CRASH 3 trial, you can try tranexamic acid for head injury. But you need to keep in your mind, the patient is on other anticoagulants, you need to do a PTNR, APTT, platelet count, fibrinogen, a TEG may be indicated, and maybe a factor 10A levels if the patient is on novel anticoagulant agents, like the newer anticoagulants like rivaroxaban, apixaban. So all those agents you need to consider that, and maybe specific antidote like idarucimab for dabigatran, adenosine alpha for your rivaroxaban, and apixaban, maybe a prothrombin C concentrate, recombinant factors, all these things to be considered. So this all depends upon patient to patient, it will vary. So always keep in your mind regarding coagulopathy, which needed to have a correction also. Coming to seizure prophylaxis, which is a very important thing that you should have a patient with seizures. So post-traumatic seizures are common complication of moderate to severe traumatic brain injury. Immediate seizure, who all need prophylaxis? The patient who is having immediate seizure within 24 hours. Early seizure, 24 to 7 hours, 7 days after injury. Late seizure, more than 7 days after injury. So these are the possibilities that you can have. The use of prophylactic anti-seizure medication is recommended for 7 days. It is not like a lifelong therapy or for an years long therapy, just for 7 days to decrease the incidence of early post-traumatic seizure. Two commonly used medications are phenytoin and levetiracetam. You know the dosing of phenytoin is 20 milligram per kg and levetiracetam is this 60 milligram per kg. So it's been hidden. So this is 60 milligram per kg is the dosing. Also you can use fosphenytoin also. Indications for ICP monitoring: intracranial pressure monitoring is indicated in patient with GCS score less than 8 and on an abnormal head CT. Elevated ICP should be suspected and ICP monitoring considered in the setting of an apparently normal head CT if the GCS is less than 8 with 2 or more of the condition. Age above 40, motor posturing and systolic blood pressure less than 90 you need to consider for an ICP monitoring. And coming to next, who need a neurosurgery consultation? Neurosurgery should be considered for all patients with known or suspected trauma with abnormal neuroimaging or low level of consciousness. If neurosurgical expertise is not available, every effort should be made to transfer a patient with moderate to severe brain injury to an appropriate facility as early as possible. And definitely you need to give consult for a skull fracture, sign of CSF leak or serosanguinous fluid from the ear or the nearis, lateralizing signs on neurological examination like unequal pupil or focal weakness, a cerebrovascular injury or a C-spine injury. Definitely a neurosurgeon should be involved. General indication for neurosurgical intervention. So different condition, you will have different indications. So when you look into the acute SDH, more than 10 mm thickness or more than 5 mm midline shift with an acute SDH of any size who has a previous experience or a declining GCS of about 2 or have asymptomatic or non-reactive pupils, you need to go for a neurosurgical intervention. Coming to EDH, more than 30 cubic millimeter of blood, more than 15 mm thickness or more than 5 mm midline shift or GCS less than 8, you need a neurosurgical intervention. Coming to cerebral contusion, comatose patient with cervical injuries and brain hemorrhage resulting in midline shift of more than 5 mm herniation, cerebral hemorrhage resulting in mass effect brainstem compression on hydrocephalus, yes, they need intervention. And depressed skull fracture and open fractures depressed greater than thickness of the cranium also need a immediate neurosurgical intervention. So key data that you need to be shared, that again I am just repeating it again: age, mechanism and timing of injury, pre-hospital and post-resistive GCS score including best eye and motor and verbal response component, pupillary size, shape, reactivity to light, head CT and C-spine result, and history of anticoagulant or antiplatelet medication or anything that is being provided to the patient. So in summary, what we have discussed for a traumatic brain injury management, as we all say, ABC management is the key, where hypoxia and hypotension should be avoided at any cost, and GCS or pupillary monitoring ideally hourly you need to do. Avoid secondary brain damage. Again and again I am repeating the same. Look for the indications of CT. You have the nice guidelines which we will discuss that in another lecture. What are the indications for CT? Consider adequate analgesia and sedation. And the tier mechanism I have discussed: tier 0, tier 1, tier 2, tier 3 mechanism, and management of raised ICP we have discussed. Keep in mind of associated alcohol or drugs or toxins that can cause altered sensorium. Admit all head injury patients for observation irrespective of the severity. So that's simple. Admit them for observation for at least 24 hours. So that's the most important message that I wanted to give you at the end of this lecture. And thank you all for your patient listening. We will come back with an nice guidelines for the CT for head injury as well as the C-spine injury will be coming soon for that. And thank you all once again.